Another phenomenon that can give you apparently an extra bubble within the fetal abdomen has been termed the pseudo-double bubble sign. And this occurs because the stomach is curved. And so because it's curved in configuration, it is possible to get a scan plane that goes through both the fundus of the stomach and the gastric antrum, therefore giving you two bubbles in the fetal abdomen. Here is an example. Two bubbles within the fetal abdomen, but if you scan further in different scan planes, you see that these connect up. However, the connecting up pattern is not that expected of the duodenal bulb connecting to the stomach via the pylorus. Rather, it just looks like the curved stomach, which is what this is. And if you look back at the original image, there is a suggestion that that's what you should be expecting to see, because the second bubble is not located in the mid-abdomen to the right of the midline the way the duodenal bulb would be expected to be, but rather is located in the left upper abdomen where you would expect the antrum of the stomach. Small bowel beyond the duodenal bulb can be seen if you really try, but if you're doing a casual search, it's only occasionally seen in normal fetuses. If you do look for the stomach, especially late in pregnancy, for the small bowel, especially late in pregnancy, it can be seen. Individual segments typically should not exceed 7 millimeters in diameter or 15 millimeters in length if the small bowel is normal in caliber, and oftentimes the normal small bowel will exhibit active peristalsis. On the other hand, in the setting of small bowel obstruction, oftentimes you'll see multiple interconnecting over-distended loops of bowel, with the number of loops depending on the level of obstruction, and you may or may not see polyhydramnios. This fetus has a high jejunal atresia. We see a dilated stomach and two additional loops, one more loop than you would expect to see with duodenal obstruction. The fetus on the right has a lower jejunal obstruction, and hence we see multiple loops of dilated small bowel. In the setting of small bowel obstruction, oftentimes you will see very active peristalsis within the obstructed loops, as we see here. Jejunal and ileal atresia are thought to be due to a vascular insult, and as such, like duodenal atresia, which is not due to a vascular insult, they occur relatively late in pregnancy. Typically, the ultrasound findings are first identified in the 3rd trimester or late in the 2nd trimester. But not all the findings are always seen. In a series of 15 fetuses with jejunal or ileal atresias, dilated small bowel loops were seen in 13, echogenic bowel in 8, and polyhydramnios only in 6, and an enlarged stomach only in 5 of these fetuses. 4 of the fetuses had ileal atresia, and polyhydramnios and enlarged stomach were not seen in any of these 4 fetuses. The polyhydramnios and enlargement of the stomach is more common the higher the level of obstruction. A dilated tortuous ureter can sometimes look similar to a dilated bowel loop. Here is a dilated left ureter, and notice that it creates a sort of hairpin loop configuration. Compare this to this fetus with a small bowel obstruction, in which you see a dilated tortuous loop that also has a hairpin-like configuration. So tracing the pathway of the dilated loops is very important in order to distinguish dilated ureter from dilated bowel. Likewise, a multicystic dysplastic kidney, when very large with very large cysts, can on the surface simulate the appearance of dilated loops of bowel. Here we see multiple cysts, but when one looks a little bit further, these cysts will not connect up the way dilated loops of bowel will. And also, if you really look at the epicenter of these particular cysts, they have a tendency to be paraspinal in location. And so getting a coronal image of this fetus, you can see that the cysts are localized to the area that you would expect an enlarged kidney to be in. And importantly, the other kidney looks normal. And this is important because a fetus with a multicystic dysplastic kidney has such a greatly increased incidence of having a contralateral renal abnormality. With that, I'd like to spend a little bit of time talking about echogenic bowel. When echogenic bowel was first described, it was actually thought to represent a normal variant that was typically seen between 16 to 22 weeks and resolved by the late second trimester. And here is an example of echogenic bowel in a normal fetus. Things were much simpler then because we didn't recognize at that point in time that echogenic bowel can actually be seen in a lot of other situations. One of these situations is if you look at the colon at term, the meconium can be very hyperechoic. In a normal fetus, typically the contents of the colon, the meconium in the colon, is most commonly less echogenic than the surrounding bowel contents. But in this fetus, you can see that the contents of the colon are more echogenic than the surrounding contents of the abdomen. But this was a fetus near term and likely is because sometimes the meconium becomes more and more desiccated as term approaches, and this was a perfectly normal fetus. Echogenic bowel can also be seen secondary to swallowed blood that's been swallowed from the amniotic fluid. It should be transitory if it's due to swallowed blood. So here we see a fetus with increased echogenicity in the bowel. This was on the basis of a placental abruption. Here you can see the markedly dilated placenta, markedly enlarged placenta in combination with the blood from the abruption, as well as increased echoes in the amniotic fluid due to blood cells in the amniotic fluid. With time, though, when the fetus was rescanned, the echogenic bowel had resolved as it is expected to do in a fetus who has echogenic bowel on the basis of swallowed blood. Likewise, this is a fetus with echogenic bowel on the basis of a subchorionic hematoma, presumably with blood cells that got into the amniotic fluid and were swallowed. Here we see the echogenic bowel, and here we see the elevated amniochorionic membrane due to the subchorionic hematoma. However, echogenic bowel also has been described in the setting of multiple abnormalities that are intrinsic to the fetus, including fetal aneuploidy, cystic fibrosis, infections, most commonly CMV infections, IUGR, thalassemia, bowel obstructions, as well as metabolic defects. We'll look at some examples of these. Echogenic bowel is seen in fetuses with aneuploidy and in particular trisomy 21. And here is an example of echogenic bowel in a fetus who also had a thickened nuchal fold with the nuchal fold measuring 6 millimeters. And we don't know exactly why you see echogenic bowel in fetuses with aneuploidies, but it has been postulated that it may be due to decreased bowel motility, which then allows for increased water resorption and thickened meconium. Echogenic bowel can also be seen in fetuses with cystic fibrosis, as in this case, and is thought in this situation to be due to the abnormally thick and viscous meconium which occurs with cystic fibrosis. This is a fetus who has echogenic bowel and a pericardial effusion, and also has a markedly thickened placenta with subtle cystic spaces throughout the placenta, and this fetus has echogenic bowel on the basis of CMV infection. And finally, this fetus has echogenic bowel and was normal in size at the time this initial ultrasound was performed, however subsequently developed severe IUGR and preeclampsia, and subsequent to that had a very abnormal umbilical artery Doppler with no diastolic flow seen. In fact, echogenic bowel is a known phenomenon to occur in fetuses who subsequently may develop severe IUGR. And so if you see bona fide echogenic bowel in a fetus, it's very important to follow growth. Why would a fetus have a normal growth size on initial scan and subsequently develop IUGR and have had echogenic bowel? The etiology of this is not fully known, but it has been postulated that it may be due to ischemia secondary to redistribution of the blood away from the bowel in the fetus with growth restriction. Now, increased echogenicity of the bowel, though, is a very subjective finding, although there have been attempts to quantify it. Really, in the final when you're finally done with it, it's subjective and it varies from observer to observer. It also varies with different scan planes and different transducer frequencies. The higher the transducer frequency used to image, the more likely you'll see echogenic bowel, as well as with the presence of harmonic imaging and other post-processing sequences as well. In fact, anything that pretty much increases contrast will tend to make the bowel look more echogenic. Here is an example of increased echogenicity of the bowel that is dependent on transducer frequency. At a frequency of 5 megahertz, you can see the bowel is quite echogenic appearing. Decrease the transducer frequency, the imaging frequency, to 3.5 megahertz, and the bowel looks perfectly normal. This is important if you're doing endovaginal ultrasound and think you're seeing echogenic bowel, because you're using a relatively high frequency imaging to do endovaginal ultrasound. And so if you're tempted to call echogenic bowel at endovaginal ultrasound, you should always look at transabdominal ultrasound. Should not call echogenic bowel just based on an endovaginal ultrasound scan, because it's very common for the bowel to look echogenic at endovaginal ultrasound. So because the observation of bona fide echogenic bowel brings up the scenario of so many possible serious abnormalities with the fetus or the pregnancy, we recommend that you only call echogenic bowel if you can see it in different scan planes with different transducer frequencies, or at least only with lower transducer frequencies. We always take off harmonics to be sure the bowel still looks echogenic when harmonics is off, and the bowel echogenicity should be at least similar in echogenicity to the bones in order to call echogenic bowel. Now, in some fetuses with small bowel obstructions, one of the sequelae is perforation of the bowel, and if the bowel perforates, this can lead to meconium peritonitis. Meconium peritonitis is a sterile chemical peritonitis that occurs or can occur with intrauterine bowel perforations of any cause. The most characteristic finding of meconium peritonitis is to see calcifications in the peritoneal distribution. And these calcifications are due to a peritoneal inflammatory response. This response can cause formation of a fibrotic tissue that's prone to calcify. And as a result, one can get highly echogenic, punctate, curvilinear, or clumped foci that may or may not have shadowing. So here are some examples of the calcifications that one can see in the fetal abdomen in the setting of meconium peritonitis. Here are some very coarse calcifications with posterior shadowing. In this fetus, though, there are multiple calcifications but no posterior shadowing. This fetus has scant calcifications, no shadowing. And this fetus has a very large clumped calcification, very coarse, very large, with shadowing. Finally, this fetus has a figure 8 configuration calcification as the calcifications wrap around the outside of two adjacent abutting loops of bowel.